So going with the idea that when something happens that hurts us, whether it's loss or trauma or some smaller version of those, if you can kind of chew up the bites and digest it, it becomes part of your nutrition, something you grow from.
Oh, that's a nice way to put it.
Yeah. And um, and so we call that processing, right? In psychotherapy language, we call that processing a loss or processing a trauma, where you bring your psychological resources to bear on it, you integrate it into your history, into your psychology, you've created a narrative that's connected with your other narratives, and that's where people grow from adversity. And I think most people have an experience or many experiences of growing from things that hurt us. You know, you're a child and you get teased in school or bullied. And if that doesn't happen too much, and if you get adequate support to cope with that, you come out stronger. You learn coping skills, you learn to get over things that upset you. You know, you grow from it. On the other hand, if it occurs in a chronic way and you don't have adequate resources, it becomes an ongoing wound that can have, you know, long-term consequences. So a lot of therapy is focused on coping skills, how to do self-talk or manage your physiological reactions. You look at DBT, mindfulness, yoga, etc. And there's a lot of good methods in there, and I use a lot of those too. However, the limit is that you're managing the symptoms that are caused by your wounds. Whereas when you can actually digest or process, or what I would say, heal from a wound, you don't have to deal with the symptoms anymore because it's not hurting you anymore. And so although I value the various coping strategies and I incorporate those into my work, I'm probably most interested in guiding my clients to actually heal from their wounds so that pain isn't driving them anymore.
Yeah, yeah, of
Now,
course.
the technical term for that nowadays is memory reconsolidation.
Right, yes.
When you take a psychological wound that's kind of stuck in a certain way in your brain and you reactivate it, you access it, you interact with it in such a way that it can be fully processed and then stored in a different way after that that's more healthy.
Right, right. Yeah, I've interviewed Bruce Ecker
Okay.
about memory reconsolidation. I think I interviewed him 2 or 3 times, and because that's such a powerful concept
Yeah.
that helps us understand a lot. Now, I sort of glossed over your combining loss and trauma, and what would be the link there?
Well, I think for a long time, the field has assumed that loss was one thing and trauma was another. But the research actually doesn't bear that out. And there's been a number of studies over the last decade or so that indicate that, well, here are the 2 main differences according to this research between trauma and loss. One is that with loss, you don't tend to get the heightened startle response, the hyperarousal symptoms that you sometimes get with trauma.
Yeah.
And the other is that other than that, you tend to get more post-traumatic stress symptoms from loss than from other types of trauma. And if you think about somebody who's been through an upsetting breakup, you get the anger, the depression, the intrusive thoughts, it's all there. And so clinically speaking, I find it useful to consider loss just one more type of trauma rather than as something discrete. Now, every type of trauma has its own twist. You know, if a stranger attacks you, that's different than if a family member attacks you, right? Because you don't get the betrayal with a stranger that you get with a family member. Every type of trauma has its own twist. But in terms of how we treat, and you know, grief is like that as well. But in terms of a treatment approach, I find that a trauma treatment approach applies to grief just as it applies to attack from a stranger, just as it applies to attack from a family member. Each specific event and situation has its own nuances. But in terms of clinical impact and in terms of treatment approach, to me, they're much more the same than they are different.
Do we have any neurological evidence about the similarity or dissimilarity?
That's a great question that I can't answer.
Me either. It just popped into my mind that there
Yeah,
might. That's research that somebody else can do, right?
yeah.
Yeah. And you say that we all suffer from trauma. I've had other guests that kind of insist that, well, we're all traumatized to some degree or another, and I guess that it goes on a continuum. But I wonder if there's any danger of overgeneralizing, and in the process, losing something in terms of maybe specificity that's needed for treatment or whatever.
I think different people could argue it different ways. And I won't argue it one way or another. I'll tell you how I do it,
Okay.
which is as a clinician or as a trainer of therapists, um, if there is a psychological wound because some painful experience hasn't been processed or digested, we're going to treat that in a certain way because it's impacting the client, it's driving negative beliefs, it's driving emotional reactivity, it's driving maybe avoidance or whatever. So whether that comes from something that would meet DSM criteria for, criterion A for a traumatic event, it's not that relevant to me as a therapist because the treatment is going to be pretty similar.